Well, good morning. I guess I should tell you who I am because I'm not currently on the Mount Sinai faculty. I was for many years. I began here at Mount Sinai in 1959, and guess with whom I was working? That was Alvin Tierstein. So we have been in some kind of communion until his death just within the past year. Also here at that time was, of course, Dr. Tierstein's mentor, and that was Dr. Lou Siltzbach, and I had the pleasure of being able to learn from and work with Lou for about 30 years until his death in the 1980s. So I usually look forward to getting a phone call. It's always unexpected from Dr. Padilla, but sometimes there's a catch to it. So she said, why don't you talk about World Trade Center sarcoidosis? So sarcoidosis is a disease with many diverse opinions. Any disease we don't know what causes it, we're going to have diverse opinions about. World Trade Center disorders, we have many opinions about as well. The difference is sarcoidosis you could discuss congenially, and discussing the various World Trade Center disorders often becomes controversial. So we're really now multiplying the opportunity for disagreement and perhaps even some degree of animus. So I've been a pulmonologist for over 50 years, and my particular interests have been normal values, reference standards, PFTs, breathing tests, occupational and environmental lung disease, and as you heard from Adam, sarcoidosis will probably one day be proven to fit into that category, and sarcoidosis itself. So here is a letter in the journal Chest in the year 2000. The title of this letter from me is Sarcoidosis, Firefighters Sarcoidosis, and World Trade Center Sarcoid-like granulomatous pulmonary disease. So why did I write this letter? Because here is an article in this journal called World Trade Center Sarcoid-like granulomatous pulmonary disease in New York City Fire Department rescue workers, primarily firefighters themselves. And we'll discuss what this article presented. And this is a group of eminent investigators from the medical department of the NYFD. So this is basically what they're showing. Here are annual numbers of cases of sarcoidosis. Now, the FDNY annually examines all its members. So this is unique, and in the World Trade Center world, this is unique because we have information about these people before 9/11/01, which we don't have about any other World Trade Center cases. So every year they would survey their workers, do x-rays, physicals, medical histories, and these are the numbers of cases of sarcoidosis that would come up. And then you see in this period after 9/11/01 this bump in the number of cases, and then it seems to have leveled off, which, by the way, this leveling off has persisted. So here is an increased number of cases chronologically linked to 9/11. So there were 26 cases which Dr. Izbicki and Dr. Prezant and co-workers presented. 9 were stage 1, 17 were stage 2. Do these cases of FDNY sarcoid-like granulomatous pulmonary disease, which is, by the way, what the reviewers and editors insisted it be called rather than calling it sarcoidosis, have sarcoidosis, as we physicians, especially pulmonologists, have known sarcoidosis in its diverse presentations for more than a century. So in favor of this belief that this is sarcoidosis is that involvement was of lung and mediastinal lymph nodes, the most typical places. These were non-caseating granulomas without other findings. As Dr. Morgenthau said, there was no evidence of bacteria, fungi, etc. So, but what was a little different about these FDNY cases, extrathoracic involvement was fairly rare, under 25%, and unusual. Instead of what we usually see, eye, skin, joints, peripheral lymph nodes, pelvic lymph nodes on pelvic CT, spleen. So a little unusual. One of our favorite breathing tests, the diffusing capacity, was abnormal in only one of these cases. Even spirometry was abnormal in less than a quarter. There was no progression in any case. And you wonder how the sampling, how the cases were selected, how they were added to the list. Although in this situation, the FDNY, as I said, we know what the group is. We know who is a firefighter, and that firefighter is examined every year. So the question of bias is much less here than it will be in the other studies. So here are two tables from Mount Sinai a number of years ago, written by Alvin and myself. And it says prevalence, this is long before we knew such a thing as World Trade Center would happen, and so on, and whether a new kind of sarcoidosis was going to emerge. Prevalence of diffusion impairment in the stages of sarcoidosis. So you see in stage 2, almost everybody, 11 of 12 patients had a low diffusing capacity. Even in stage 1, which we thought, gee, the lung is spared because we don't see anything on an X-ray, over half had an abnormal diffusing capacity. That was not true in the FDNY. And here, prevalence of spirometric impairment. So let's look at the thing called VC, vital capacity. And we see that in stage 2, and remember, most of these FDNY cases were stage 2, 2/3 had abnormal spirometry. So these cases were kind of different. So here's an interesting article, same group of people. Dr. Prezant was the chief author. Incidence, prevalence, and severity of sarcoidosis in New York City firefighters. Interestingly, the year is 1999. The journal remains chest. So Dr. Prezant noted that that firefighters in New York City seem to have more sarcoidosis than would be expected. He presented 25 cases. 21 of them were new because they were detected on the X-rays that firefighters undergo every year, which means you're more likely to pick it up than in anybody else. So if you're looking at cafeteria workers or steel workers or physicians or name it, they're not going to get X-rays every year, and they could have sarcoidosis, and no one would ever know. So most of them were stage 1, because that's what you pick up in an asymptomatic person by X-ray. All of them were mild, and obviously part of the reason that you were picking up more cases is that you were looking more carefully to pick up cases. So there was certainly a question as to whether firefighting is one of the many occupations that has an increased incidence of sarcoidosis. And this was shown before 9/11. So here is another paper. Unfortunately, the year of publication is 2008. This is an abstract, and it has not yet been followed up by a definitive publication. This is from the New York City World Trade Center Health Registry, looking at almost 42,000 people surveyed who were exposed in some way to and at the World Trade Center site But these are extensive telephone surveys, and there were 179 self-reported cases of sarcoidosis in residents, workers, and commuters who were in some way exposed to the World Trade Center site. So this is more than one would expect in another population. Absolutely no information on clinical findings, stage, radiographic stage, Adam, since there's no stage of sarcoidosis, or how the diagnosis was made. And here is the last such paper which enables us to talk about World Trade Center sarcoidosis. Sarcoid-like granulomatous pulmonary disease and World Trade Center disaster responders. So this is a group from Mount Sinai. You notice that Al Teostein is the senior author here. And this is the World Trade Center group here at Mount Sinai reporting their experience. Their experience is unique for responders. So responders are people who were either volunteering or required to be there sometimes immediately, even before the buildings imploded. So what was found in this study, and this was just published in the American Journal of Industrial Medicine, 38 cases among the 20,000 responders seen in the clinic here at Mount Sinai. Well, actually, the Mount Sinai Clinic is one of 5 around the metropolitan area. Another one is in Queens, and that's the one I'm the treating pulmonologist at. So those are our cases as well. The peak incidence was like the fire department one in 03 and 04. 32 cases entered the program with biopsy-proven sarcoidosis. In other words, some other doctor saw a patient who had various problems, made the diagnosis of sarcoidosis, and said, hey, they should know about this in the World Trade Center program. So you have that very strong selection bias in this. 19 of the 38 cases, exactly half, had typical extrathoracic involvement, and no information was given about stage, other PFTs than spirometry, therapy, etc. So this initiated a letter from me about this report to raise these questions. So is sarcoid-like granulomatous pulmonary disease truly sarcoidosis? Trying to answer that question, I think the World Trade Center cases presented in this last article from the treatment programs at Mount Sinai and elsewhere seem to be typical sarcoidosis. They have all the characteristics we would expect. The FDNY cases seem a little less typical and maybe not. Is it important to try to make this distinction? I think so. To properly classify disease means you can establish and compare prevalence and incidence, because if you can't make the diagnosis, you can't say whether there's more or less of it. And you want to place any disease in its clinical perspective. So how can we make this distinction? Oh, clinical course will help, but no disease has a more varied clinical course than sarcoidosis, so that's not so easy. You could look at ACE. It should be elevated. Other biomarkers I wish we had, so we don't have a really cogent biomarker. And I'd like to bring up this test called the Klein-Siltzbach test, because here is a test, 84% positive in biopsy-proven sarcoidosis. That's very impressive for any test. More important is under 1% false positive. So here is a positive test result. You don't have to tell the patient, well, it could really mean this, it could really mean that. It means sarcoidosis. This test, you could tell from the name of it, is uniquely identified with and available at Mount Sinai. So physicians elsewhere, I'm currently at Beth Israel, which is only some few hundred blocks downtown from here, but we can't do a crime test. Here is a quote from Dr. Siltzbach in the article in which he reported the findings of this test. This was in 1964. Wide use of this test may help to determine whether sarcoidosis is the same disease in its various settings. Now, I can't think of a more cogent rationale than this. So here is Dr. Siltzbach's paper, The Crime Test in Sarcoidosis. It was published in JAMA, a study of 750 patients. This is in the days when single authors did research and published papers, and you didn't see 29 names after an article, the names being longer than the information purveyed in the article. So in summary, can we assess incidence and prevalence of sarcoidosis in WTC-exposed populations? Is it sarcoidosis? Is there another granulomatous lung disease attributable to the multitude of dusts and fumes which were present in the site? And the composition of the dust and fumes varied from day to day and from one part of the site to the other. Is there selection, surveillance, recruitment bias? Absolutely, because if patients who have a disease are told to come to your clinic, then your clinic is going to have a higher incidence of that disease, right? It stands to reason. What is the whenever you look at prevalence or incidence, you say this is the number of cases in this population. The population is the number of people exposed at ground zero. Well, we have no idea of what that denominator is. We know how many people are registered in the programs. We know how many people were contacted through the registry. We don't know everybody who was exposed, and somebody is going to come down with some disease whom we don't know anything about. So we have this enormous problem of what is the denominator. Will further follow-up of the population help? Unfortunately, I have to conclude that possibly not, because there was a spike following 2001, and then everything seemed to level off. So following them another 20 years may not tell us anything. Why is incidence important? I'll quote Dr. Tierstein in this, and Dr. Padilla will remember this. One of the first meetings not long after 2001 about lung disease, and this was for not dissimilar disease, interstitial lung disease from World Trade Center exposure, and the question was raised, how do you tell? And we looked at all the few cases around, and they all had microscopic examinations, electron microscopic examinations. And the question was, could we attribute this to the World Trade Center exposure? And Dr. Tierstein said the only way we could answer that question is by population studies. You can't tell from the individual case. So, but there are the problems with population studies. How else can we try to attribute cause? And I think some of this is useful, and a lot of this is being done right now. You could look at electron microscopy and do mineralogic analysis of lung tissue and say, hey, there's something funny, carbon nanotubes or mineral particles in this lung. We don't see that in sarcoidosis. Various immunologic studies, we could expose animals to the stuff that was present at ground zero. So these are some of the things that are and should be done. Last point, how to deal with specific cases. So here, I'm not showing you the journal Chest or JAMA. Here is the New York Times, and the date is 2007. For the first time, the city connects a death to 9/11 dust. So here is this woman who died of sarcoidosis, cardiac sarcoidosis, and after many years, and after many episodes of wavering and erasing what he said before, the medical examiner said, well, now I conclude that this case of sarcoidosis, which was present, she had cardiac sarcoidosis before 9/11, I conclude that it was caused by World Trade Center exposure. This raised a few eyebrows. And here, this is now, this year, New York Times. New death is added to the toll from 9/11, so this case of sarcoidosis was decided by the medical examiner to be due to the World Trade Center, and his death is now officially a homicide because this was an act of man which deprived people of their lives. So the scientific rationale for these decisions we have just reviewed. And with that, I conclude, and I guess all of us will try to answer questions.